Adolescents are also at risk because of growth spurts during puberty and poor eating habits. Children at risk for iron deficiency anemia include infants given low or non-iron fortified formula or breastfed after 6 months of age without iron supplementation, premature infants or low birth weight infants who have reduced fetal hemoglobin supplies, possibly due to low stores of iron in utero, children who have a gastrointestinal disease such as chronic infection, chronic diarrhea, celiac disease, or an intestinal parasite, and infants, children, and adolescents who have low levels of iron in the diet. They would be those who were breastfed exclusively after 6 months of age, drank cow's milk instead of formula before 12 months of age, started solid foods later than 6 months of age, lack meat in the diet, or have an inadequate food intake in general. Signs and symptoms of anemia include pallor, fatigue, weakness, irritability, and an inability to concentrate. Clients with anemia may have shortness of breath, a sore, swollen tongue, lesions in corner of the mouth, and pale conjunctivae. They may have a poor appetite, headache, dizziness, and cravings for non-food items. That's called pica. They may demonstrate impaired psychomotor and cognitive skills, slow cognitive development, and a shortened attention span that can impair learning. In addition, they may have weakened immunity. In fact, children experiencing recurrent infections should be tested for anemia. How is iron deficiency anemia diagnosed? Diagnostic testing begins with a complete history and physical, including a dietary history. Lab results indicating anemia include low hematocrit and hemoglobin, morphological changes in red blood cells, low serum ferritin, and low serum iron. Treatment for iron deficiency anemia includes nutrition counseling and supplemental iron therapy. Emphasis on iron-rich food sources is an important component of prevention and treatment. Good sources of iron in the diet are as follows. With a well-balanced diet that is rich in iron, there is no need for supplementation. Children who are picky eaters might need a vitamin supplement that includes iron. While oral iron supplements are best absorbed on an empty stomach, many people experience nausea and have to take supplement with food. Your nursing care concerns focus on preventing and identifying children at risk for iron deficiency anemia, identifying dietary habits that contribute to anemia, initiating iron supplementation, and developing a dietary plan. In addition, you will administer iron supplements PO, usually iron sulfate, 2 to 3 times a day, between meals. You'll advise parents to have the child take liquid preparations through a straw to prevent discoloration of the teeth. Promote vitamin C supplements and foods rich in vitamin C to enhance absorption. You'll administer IM meds via Z-Track method when oral iron is not tolerated. Give iron-fortified formula or give iron supplements to children who are breastfeeding, and provide family education. You'll teach about administering supplements, dose, route, time, and side effects. Inform families that the stools may be tarry and dark green or black in color, and that the other side effects include constipation and discolored teeth. Teach about nutrition, including iron-rich foods, what to avoid, such as giving iron with milk, and increasing iron intake, particularly in adolescents. You'll also teach parents about the importance of follow-up care and periodic blood evaluations. Next, we'll review hemophilia, the oldest known hereditary bleeding disorder. Inherited through an X-linked recessive gene, the disease primarily affects males. Low levels or complete absence of a blood protein essential for clotting causes both of the two major types of hemophilia, A and B. People who have hemophilia A lack the blood clotting protein, factor VIII, and those with hemophilia B, also called Christmas disease, lack factor IX. Both can result in uncontrolled bleeding from wounds and into the joints, muscles, and other body tissues. The severity of the disease is related to the amount of clotting factor in the blood. About 70% of children with hemophilia have less than 1% of the normal amount and have severe hemophilia. Just a small increase in the blood level of the clotting factor to 5% of normal results in mild hemophilia with rare episodes of bleeding, except after injuries or surgery. The signs and symptoms include the cardinal sign of hemarthrosis, that's bleeding into the joints, plus excessive bleeding from infant circumcision or any break in the skin, bruises in varied stages, hematuria, decreased hemoglobin and hematocrit, elevated white blood cells and platelets, nosebleeds, bleeding gums, and in adolescent girls, abnormally prolonged menstrual flow. Complications of hemophilia include uncontrolled bleeding, permanent crippling from hemarthrosis, muscle contractures, intracranial bleeding, hypertension, and renal impairment. Diagnosis begins with a complete history and physical. Lab tests include CBC, platelet count, prothrombin time, or PT, which would be normal, partial thromboplastin time, or PTT, which would be prolonged, bleeding time, normal, and liver studies to rule out other causes of bleeding disorders. The primary medical treatment is replacement of the missing clotting factor. Products used include factor VIII concentrate, which is made from pooled plasma or a genetically engineered recombinant DDAVP, that's desmopressin, a synthetic form of vasopressin, is the treatment of choice for mild hemophilia. Other drugs are corticosteroids for hematuria and hemarthrosis, NSAIDs and analgesics, but keep in mind the possible effects they have on platelet function, and epsilon aminocaproic acid, which prevents clot destruction. While current treatment has greatly improved the outlook for most children who have hemophilia, others develop inhibitor antibodies that block the activity of clotting factors. When inhibitors are present in large numbers, very high and expensive quantities of transfused clotting factors may be required to control bleeding, and for some, may not be effective. The major cause of disability in children who have hemophilia is chronic joint disease, and life-threatening hemorrhage is a constant risk. Let's move on to your nursing management. First and foremost is to prevent bleeding and to recognize and control it. You'll avoid invasive procedures, venipuncture, and injections. When they must be done, you'll apply pressure to insertion sites after the needle is withdrawn. Assess old venipuncture sites and joints, urine, stool, and NG fluid for visible and occult blood. Aspirin or aspirin-containing products are contraindicated. You'll also want to prevent the crippling effects of bleeding. During bleeding episodes, elevate and immobilize affected joint. Encourage active range of motion after acute episodes and regular exercise in general. For pain management, you'll apply ice to the affected joints and administer analgesics. Your teaching for family support and home care will include the signs and symptoms of bleeding, prevention of bleeding, and nutrition counseling, basically a diet designed to support growth but to avoid excessive weight gain and to prevent constipation. And what about safety issues? The child will need protection from sharp edges and falls, plus avoidance of rough play and contact sports. You'll also cover administration of factor replacement at home as indicated and genetic counseling. A great deal of progress has been made to reduce the exposure of children with hemophilia to transfusion-transmitted diseases by making the blood supply safer and by providing replacement products from sources not involving blood. Another blood disease affecting children is sickle cell anemia. It's an inherited autosomal recessive blood disease, usually diagnosed in infancy. Sickle cell anemia is one form of sickle cell disease, a category of blood disorders caused by defective hemoglobin. Hemoglobin, a component of every red blood cell, is an iron-rich protein that gives blood its red color. Hemoglobin enables red blood cells to carry oxygen from the lungs to all parts of the body and to carry carbon dioxide waste to the lungs to be exhaled. Red blood cells with normal hemoglobin are smooth and round and glide easily through blood vessels. After delivering oxygen to the tissues, red blood cells with sickle cell hemoglobin may become hard, sticky, and shaped like a sickle used to cut wheat.